get from him. He'll be here in about 10-15 minutes, so just kind of hang on. Give me your range again.
Yeah.
Nice.
Give it a try, see how that works. Not bad. Let's see. Where will I find this one out?
Pharmacology. Unless he has his own thumb drive, he's probably going to have his own thumb drive.
Okay, I'm not going to worry about it.
I had a question. So on those computers, for whatever reason, they keep getting a mouse or something like it locked.
Reset it, maybe? Like restart it? I don't know.
That's usually my philosophy, but
Well, I know. So,
a little bit. I would expect parts. I think I got funds from friends.
it's called
Friends.
I think.
Oh, we can do that on friends, 6 or 6.
Yeah.
I mean, whether or not they're inebriated or not.
Assuming that's one.
Well, we want them able to make decisions for themselves.
Oh, okay.
So they have to be able to consent, otherwise that would be battery.
Yeah.
So
What's that? Yeah, exactly. Yeah. Thanks, Chris. Have a sound mind. No, I think I need that.
you figured out.
Sleeping car? What happened, dude? One night or what? Yeah.
Talking about it, we're talking about a semester course, and so we're just like, next week, yeah, it's another subject. But yeah, very excited. Played with everything, most of it, just like, kind of like, put those together, so you know, you gotta do it time and time again. So,
Check out those things.
yeah.
I got some great handlers. I actually made myself a 20 in my camera.
Really?
Yeah.
How many do you have to get here?
I only did 10. And I did my.
So you want to be Ivy buddies?
You want to be Ivy buddies?
Anybody? Anybody raise their hand?
Oh, really?
Really?
You're like, I need to go like 10 in one day. Do they let you get, like, if you want?
We're also young and healthy. My hardest was I demographic. There's that 80 to 90-year-old female. We're being rolled or hungry. Yeah, and they're like wine burger. You go in, you're like, oh God, Dad's watching me. I'm going to get my friend. Look at that. Don't worry, I'm not your teacher.
Oh, when I'm telling you. Yeah. No, and I'll expect to run into all you guys out.
It'd be a
What's that?
It's definitely in house. We have a massive.
Oh, the lumber. Yeah.
Yeah, they just kind of kept us around and around. So.
They shut down like 4 hygiene systems around there. They had a big lake. Choco Lake right there. They got a whole thing, and they're like, "You need to stop using water." So that was well, it was super tough because it's like the exterior lining up.
Yeah.
I saw the patient. Yeah, I did actually. I'm glad it's good. The kind of guys that are turnouts. It's like one measure. It's just kind of.
And what kind of monitor setup and stuff? So, is that what happens when we're paralyzed or something?
It was a malfunction. A guy ended up running in there and took it over. And that's when it ended up starting. I can always put something on, but I'm just trying to think about one of my cases. What do you want me to talk about? Because some of these I'm going to be saving.
You've had your fair share.
Right? I'm going to be saving some of these.
Oh, you don't go too far.
Yeah. But I got a good way to introduce this stuff into something back here.
So, just going to be touching base with you guys on a couple of things. So, you guys have got your red bag, right? Has anyone checked on them lately? Is everything all there? Just asking.
Yeah, we haven't had a call. Why not? Yeah.
Yeah, so I'm just going to give you a couple of things. Gary was having me talk to you a little bit about my weeks going on. So, I also work part-time at Medic 42, if I hadn't told you that already. And I've been having tons and tons of really good calls that I'm doing transports of 45 minutes and an hour on. So I've got 5 tubes in a period of 3-week scan. I've been RSIing. I've had a couple of codes. I've had a lot of stuff that's going on there. So I'm also recognizing in myself that it's like, yeah, I'm getting a little bit overworked. So I'm kind of stepping back for a little bit because I'll be up all night long and all day long. So I want you guys to recognize we're there. You guys are not there yet, hopefully, on that spot. But I'm like, okay, yeah, I've got plenty of good cases for you guys to run because these have been fantastic calls. But here's my experience where I guys want to go to and why I'm referring to the red bag. I write on a particular ambulance company, which I'm not going to mention. But I've had on 5 of my calls something missing on that ambulance, including a patient that I've got bagging that we're going on is on oxygen. And again, when I get in the back of the ambulance, I'm not very sure of everything that's on there. Bagging patient, I found out that I'm bagging the patient from the O2 tank on the bed. I'm like, we're out of oxygen there. Let's move over to the ambulance. Okay, let's go ahead and switch out that O2 tank. Okay. Start looking for it. Well, I think it's on the seat underneath it. Okay, I'll get up. I go over to the airway seat. We don't have an extra O2 tank. So I'm bringing in a patient who needs to be on oxygen in past the ER docs who are looking at me with nothing on there, and I'm just shaking my head, and they know exactly what's going on. So these are the type of things. I've had to look for a BBM on one ambulance, and it's in the compartments that are tagged. You pop the tag and you open up and it's not in there.
No, you can't trust those tags.
So that's where I would say, so wherever your company's on, and I've also been on a medic unit particular, I'm not going to say where, but where I've had someone else who's supposed to be on the ship before me and said, yeah, everything's fine. And I go in and search it, and there's no blades in the airway bag. So I make sure I check, and it's really easy to be on shift after someone who you know. You guys all work with people, right, that you're after shift with? And they tell you it's trust, and you're like, yep, I know that person. Yeah, I'm not going to trust him. Don't trust them. Again, because they may have said that from the person before them. Might have said everything's good, and they didn't have a call, and they didn't run through it. So all of a sudden, I open my airway bag, and there's nothing in there, and I'm like, I'm glad I checked this on shift before I got on there. So that's something I want you guys to be aware of and be known on, is check the stuff. So what I want you guys to do now, and I was mentioning it to people in my group yesterday,
You got thumb drive? You want
check the medic box. Check your ACLS gear. Again, ask your medic first. Don't go touching gear, because some medics will get upset when you're doing something. Say, yeah, no, I really want you to go and look at it. But start looking at that. Start getting used to finding where things are and get in that habit. It's really easy. And I'll tell you, I am one of the first to say I can get complacent very easy. And I've come on shift before where I trust somebody. And whose fault is it if it's not there? It's on me. Yeah. You blame C shift, but yeah. It's a phantom shift for you guys, right?
So you want to do that one first, or you want to do pharmacokinetics?
I'm doing
okay.
2 first.
Yeah.
But see, when it comes on scene, though, then who's does it come down to? It comes on me. So if I didn't check my gear at the time I'm out there and I don't have something, it's on me. So I did not mess with your red bag. Minus someone's bag, I took a Broslow tape out of it and I put it back because I borrowed it yesterday. You guys saw me all run out of here yesterday. So I have not messed with your bags. I told you I'm not going to mess with your bags. So I won't do that to you, but your bags can get messed with. So I want you guys to get in the habit, especially on a lab day, like yesterday was a lab day, especially on a lab day, just make sure you're going through your bags, just do a quick inventory, make sure you got it. Because you don't have it on your spot, you're going to wish you did the check.
Clickers also do.
Yeah.
The laminated inventory sheets.
Clickers.
Gary,
So again,
do you have the laminated
they
inventory
should
sheets?
be in that front pocket. So you look at the front of the bag.
So the trauma
front
department.
So just along the same lines of what Doug's talking about, as an old dog that has survived for years and years and years, one of the survival tips for you, and you take it for what it's worth. For all these years, everything that I do is standardized in terms of coming onto a ship. So it doesn't matter if I'm coming on from Doug, I would do the same thing if I'm coming on from somebody else along the way. And that is, I will always start with checking my bag. I always will start in terms of checking my monitor. It's not about Doug. It's not about anybody else that I follow along the way. That's standardized in terms of knowing that's for me, I'm good to go. And oh, by the way, the other thing is, even after all these years of doing that, when I'm looking at my medications, in my mind, I'm running doses in my mind. If I have this, what's going to happen in terms of my dose? If I have this, how am I going to administer it? If I have this, and the list goes on and on. So again, take it for what it's worth. That's survival tips, and that will work well for you if you end up doing that. Yeah?
Stop it.
Well, the other problem, we don't really want it back here. How many seconds is over? Go that road. Hey, leave us out of this.
So is this a vote of no confidence or what?
There's always a computer on.
Are you turning it off?
I'll go to the bathroom.
There you be.
Good to go?
Yep.
All right.
All yours.
How's the day gone so far?
They had acid base this morning. So.
Acid base. Oh, that sounds awesome. Older than I look. Okay, I've been married for 14 years. I've got 3 boys. 36. I'm an old man. I'm not dirt like Gary, but I'm old. Acid base. Acid base lectures? Oh. All right. No, this isn't nearly that bad. Sorry, I'm coming in here a little bit late. My son got his tonsils out yesterday, and so he's just like, you know, living it up, but dying at the same time. And we're trying to figure that out between me and my wife. And I guess this whole week, I don't know if it's the same here, but the kids it's half days until Thanksgiving. It's crazy. But they get to call it, they get it counted as a full day. As long as they have lunch at school, apparently it's counted as a full day. So they come home right after lunch, but it's a half day. So we're trying to figure out how to make that work.
We'll do that here.
What's that? I know, right? All right. So, I mean, this is just more fun stuff. My clicker's not working. Let's see. All right. Maybe I'll just. Oh, it's because what's his name? Doug. Messing with my system. All right. So, objectives. This is pharmacokinetics and pharmacodynamics. This is so much better than acid-base. Right? So goals, obviously, be able to define what pharmacokinetics and pharmacodynamics mean. We're going to talk about medication absorption, what goes into medication absorption, and then what affects medication absorption. All of this is obviously very pertinent to what you guys are doing and medications that you're giving, and understanding how they're metabolized, how they're absorbed, why they last as long as they do, how you can count on certain absorption rates and all of that stuff. So although it's honestly not too bad. It's not painstakingly painful like going through the, you know, immunology cascade of all the CD factors in your lymphocytes and all that crap. So we're going to be talking about the medication distribution. We're going to be talking about biotransformation. Biotransformation is basically how a molecule of medication, how a medication is changed in the body, either to be excreted or changed to be effective. So there are a lot of medications that are given where the form that the medication comes in is not an active form. It has to be changed by a part of the body before that medication can actually become active. So that's all part of biotransformation. So we'll talk about elimination from the body, the factors that affect elimination, which are a lot of the same factors that affect absorption. And then we'll just talk about a couple of special considerations. All right, we kind of went over that a little bit. So pharmacokinetics, this is the study of how medications enter the body and then reach the site of action. You mean, how do they get from where you're giving it, whether it's an IM injection, sub-Q injection, whether it's an oral medication that you're giving, like albuterol that's inhaled. How does it get absorbed? How does it then get into the bloodstream and get to the area where it's going to be effective? And then how does the body eliminate it? And then we'll talk about the factors that determine, because pharmacokinetics is basically the duration and intensity of a medication's effect, and why that happens. So this is pharmacokinetics, is how the body is able to break down medications. So the two primary mechanisms in pharmacokinetics is active transport. And the big active transport basically means energy. Energy is required for transportation of those medications, those molecules. The most common form of active transport is the sodium-potassium pump. Sodium-potassium pump requires ATP. That's why you need ATP. The two big things involved in making ATP inside of a cell, so that sodium-potassium channel can work, glucose and oxygen. And that's why your body is so dependent on glucose and oxygen, and even minute changes in glucose and oxygen affects everything in your body. Because basically every nerve signal that goes to every part of your body, meaning nerve signals that are telling the heart what to do, telling muscles to move, voluntary and involuntary, are all controlled by that sodium-potassium pump. That's where action potentials come from, sodium-potassium pump. So if you don't have ATP, if you don't have the oxygen and the glucose to make the ATP in order to continue that sodium-potassium pump, the whole system goes down. Passive transport does not require energy. So the passive transport is just osmosis. You guys understand what osmosis is, right? That's the whole, I guess, factor involved in osmosis is concentration of solids, right? Solids in solution. If you've got a higher concentration of solids on one side of a membrane, there's going to be movement of fluids across to try to balance that concentration, right? Diffusion, filtration. This is just passive transport across the cell membrane. The 4 factors that affect the concentration of the medication, how it's absorbed, how it's distributed. Distribution is mainly dependent on your circulation and all of the factors that are involved in your circulation. Blood pressure, cardiac output, all of that stuff. Metabolism, that's how medications are broken down, either into an active form or into an inactive form to be eliminated, and then, of course, elimination. So medication absorption. This encompasses the progress of, the pharmaceutical dose, and then how it's passed across tissues. And the bioavailability is how much concentration is actually absorbed. Because, you take a pill, you swallow it, it's digested. A certain concentration of that medication is actually absorbed by the body. The rest is eliminated, right? So it's all based on its bioavailability and how it's absorbed. So the factors that are involved with that absorption is the solubility of the medication, and sometimes solubility is changed by certain proteins in the body. That's why you have albumin. Albumin binds to a lot of different molecules, including medications. Medications are made to bind with albumin so that it can be soluble in different tissues. Fat soluble, water soluble. Medication has to be water soluble in order to be excreted from the kidneys. So sometimes it has to be changed into a soluble form. So concentration of the medication, pH of the medication. You guys learned all about that today, right? The site of absorption, that matters. If it's under the tongue, if it's in the lungs, if it's the digestive system. All of those factors are involved in how it's absorbed. So obviously, it's absorbed quicker and better in certain locations than it is in others. The surface area. So obviously, a pediatric patient is going to have a decreased surface area in the digestive tract. So the rate of absorption from a certain medication is going to be different. And a lot of factors go into that. That's why you can't just decrease doses and treat pediatric patients like little adults, right? Because there are a lot of different factors that affect how that medication is absorbed. They have a different cardiac output. It's not just a direct linear correlation with its size. And same thing goes along with geriatric patients. All their stuff slows down. So they don't have as much albumin. They don't have as much protein in their system. They have decreased cardiac output. They have lower blood pressure, or atherosclerosis caused them to have a much higher blood pressure. All those things affect its bioavailability and the overall absorption of that medication. So here's just kind of an example of IM injections versus sub-Q injections, and that's why certain medications are given IM and others are given sub-Q. Insulin is given sub-Q because we want it to last a while, right? They get, a daily, depending on the medication, but like Allantis, long-acting insulin medication, that's given daily. That's because it's slowly absorbed over time, and it stays at a therapeutic level longer. IM injection is going to be absorbed fairly quickly, but it's going to go away quicker. Why do you think that is? What's the difference between sub-Q and IM? Okay, I heard vascularity. Blood flow, right? You've got a lot better blood flow to your muscles than you do in sub-Q. So the absorption is going to, that's why you give IM epinephrine, right? Because you want that medication to work quickly. You don't want to give that sub-Q. And the same thing with insulin. You don't want to give insulin IM. It's going to have a much different effect. And then you've got your different correlation of IV and oral medications. Generally, an oral medication is going to become therapeutic at around that 1 hour mark. It reaches its peak between 2 and 3 hours, and then it starts to go down. And it'll lose its effectiveness, meaning if this therapeutic concentration is right here, you need to be able to give that next medication before that therapeutic level gets too low so that you can maintain a therapeutic concentration over time. And that's why medications are, given Q4, Q6, Q8, because they're trying to maintain a therapeutic concentration of that medication. Because oftentimes, like ibuprofen, if you're giving that for inflammation, if you don't stay strict on that, if you're treating a certain, injury with ibuprofen and decreasing the inflammation in that body, if you only wait until it's painful, then you're starting the system over again and you're making your body work harder. That medication is much less effective. So you need to take that as it's directed, Q6. Even if it's not necessarily painful at that 6 hour mark and you're like, oh, I can wait until 12 hours, well, that medication will be much more effective if you take it as directed so that you keep that therapeutic concentration. Does that make sense? So this just kind of gives you a list of different absorption sites. So oral and subcutaneous, those are slow. It's interesting that topical medication is much quicker than a subcutaneous and oral, right? But you've got good blood flow at different areas of skin. You also have good surface area for absorption. So that's going to be a little bit better than some of these others. Those are moderate. Topical, IM, intranasal. Your rapid absorption, that's going to be areas where you have a lot of blood flow. Rectal, sublingual, endotracheal. I don't know why they have intralingual. I mean, nobody injecting medications into your tongue, right? That seems silly. I've never even heard of a medication that's given that way. But.
I guess not. I was thinking, like,
Sure, like a lidocaine injection or something like that. That's generally not intralingual, but it does hit nerves that control the tongue, so your tongue will get numbed up. But those medications are, even though it's a small layer, it's considered more of a sub-Q injection into your gums. So, and then you've got, your immediate, and those are your intraosseous, and then IV. Obviously, it's directly into the blood flow, right? So your concentrations in general circulation immediately. So distribution process is how it's transported from where it's given to where it needs to act, right? Factors affecting that is all dealing with your circulation. So your cardiovascular function, cardiac output, your blood pressure, the blood flow to that area, medication storage reservoirs. So in certain areas of your body, medications can be stored, like in the spine. You've heard of those people that take LSD or acid or something like that, and then months later, something happens. They have a twist, and boom, they get a response to that medication that they took a long time ago. And that's because their body stores it in certain areas, like in the spine and certain ganglia. And then the physiological barriers that affect distribution. Biotransformation, like we talked about, this is the process of how the medication is changed, how it's broken down either to an active form or eliminated. Prodrugs, so these are two different processes of biotransformation, or examples. So a prodrug is a medication that's given that it doesn't work until the body breaks it down into its active form. First pass effect is the concentration that you give to the patient is not the same as the concentration that's actually absorbed and into the circulation. So the most common and most obvious example of first pass effect is your liver. So all of those oral medications are digested into your GI tract. They don't get into general circulation until they pass through your liver. Your liver usually breaks it down, So it gets into the circulation in a lot lower concentration. That's first pass effect. Diazepam is an example of a prodrug. So the diazepam that we give, Valium, is minimally active. It doesn't become effective until it's broken down into the desmethyldiazepam. You guys don't have to memorize that. That's just an example of a prodrug. And then it's further broken down into its inactive form where it can be excreted. Elimination, this is the movement, obviously, from the tissue back into the general circulation and then excreted, either through your GI, through your renal system. You can get excretion through your lungs. There's a lot of different places. And here's examples of those. So respiratory system, give me an example of something that's eliminated through your respiratory system. CO2, right? Renal system, obviously that's a big part of excretion. A lot of things are obviously broken down and eliminated through your urine. Then you've got your liver, biliary system. Bile is designed to bind to certain elements in your GI tract to get them out so they can't be reabsorbed. So factors involved in an elimination. This is half-life, accumulation of that medication, how it's cleared, and then what we talked about before with its onset, peak, and then duration, how long it actually lasts in your system. So an important part for you guys, for pre-hospital personnel that are giving a lot of these life-saving medications, is that obviously medications don't work very well if you don't have good blood flow, right? And those hypotensive patients, those cardiac arrest patients, and that's why CPR is, you know, it's always back to BLS, right? It doesn't matter what medications you give or how well you intubate a patient if you're not doing CPR correctly, right? Or if your partner's not doing CPR correctly. So a lot of times you guys are leading an arrest, right? You're giving orders. You need to make sure your primary objective is to make sure whoever's doing CPR is doing that well, because everything else doesn't matter if CPR is not done well, right? Don't waste time trying to intubate a patient for 20 minutes. Make sure that the CPR is done correctly. Put in an eye gel. As long as you got good chest rise, you're moving air, you're good. Intubation is much less important than that CPR, although it's a lot cooler to intubate somebody, right? But that's not going to save their life. That CPR is going to save their life. So pharmacodynamics. This is the mechanisms by which the medication dosages act and how it's changed in the body. So they're changed in 4 different ways. They bind. So the medications act by binding to the receptor sites. Certain tissues in your body obviously have different receptors. So that's why medications act on certain areas of your body. We give medications for the heart. We give medications for the kidneys. We give medications for tissues. And that's because they're designed and bind to receptors that are only found on those tissues. Once they bind, they set off a chemical pathway that changes the properties inside the cell. Then the cells then react and either release other medications or change in a way for the desired effect of that medication. Receptor binding sites. So these are protein molecules that sit on the outside, on the membrane of the cell, right? And every cell in your body has millions, countless receptor sites that'll change how that cell acts. And they have very specific protein makeup that can only bind to a certain receptor, right? So this kind of goes along with what I'm saying, is that it's an exact fit. And if you can think of it like a key into a lock, that only that kind of protein can set off that reaction. So an agonist is something that initiates the expected response. The antagonist blocks that receptor So whatever was supposed to set off that response can't. Give me an example of an agonist. Explain. Right. So Narcan would be the antagonist to that receptor. So heroin, correct, is an agonist, binds to certain receptors in the body to give a desired effect. But physiologically, what does it do with heart rate, with brain function, all those things? It's basically a parasympathetic response, right? And the antagonist binds to those receptors stronger than the agonist does. And if you give the antagonist with enough concentration, it's going to bind all those receptors, then you'll have no effect from the agonist, right? So good. Another example would be, your beta blockers, your beta agonists. So give me an example of a beta agonist. Can you think of one? Albuterol is a beta agonist. Activates that beta response. So that causes bronchodilation, right? But also has other effects as an agonist. Bronchodilation is a sympathetic response, so it's also going to bump up the heart rate, bump up the blood pressure a little bit, right? Notice that when you give albuterol in kids, they get all ramped up. Sometimes older people that have never gotten albuterol, and you give it to them, and what the heck's going on? Everything bumps up. And a beta blocker is the antagonist. So it'll block those receptors of the heart that normally would speed it up and cause the automaticity of the heart to take over and goes down to its kind of default setting, keeps the heart rate at a slow rate, right? So in certain patients that have asthma but also have high blood pressure, you give them a beta blocker that, like propranolol, to keep their heart rate and their blood pressure down, but that beta blocker also will cause some bronchial constriction, right? So you don't want to give propranolol to an asthmatic, right?
We give them together.
Well, it depends on what concentration. You generally don't want to give them together because they're going to fight each other. And depending on which concentration you give higher is where you're going to have the desired effect. Also, some medications are stronger, they bind stronger, so it takes a much higher concentration to overcome that.
Isn't there beta 1 and beta 2, which controls?
Yep, we'll talk about that too. So yeah, we got alpha 1, alpha 2, beta 1, beta 2, and each of them control like a different effect. So true. So that's why. So propranolol is a non-selective medication, right?
Oh, okay.
It blocks both beta 1 and beta 2.
Oh, okay, so it's
Metoprolol was designed later for that exact purpose, because they're like, we can't give propranolol on all these patients that have high blood pressure but also have COPD, which is almost everybody that has COPD has high blood pressure, right? So they're like, oh crap, we can't give metoprolol to these patients. We need to design a better drug that's selective, only blocks one of those. So it doesn't affect the lung part, only affects the heart part. And that's where metoprolol came in. It's a selective beta blocker. So mechanism of action. We talked about that. Organ sites have multiple receptors, and this kind of receptor binding action we're going to talk about a little bit later. But this is kind of a generalized idea of what we're talking about. So epinephrine, this is a medication that binds to beta receptors, right? Binds to a beta receptor and causes the kind of a sympathetic drive, right? Increases heart rate, increases contractility, all of that stuff. Propranolol, which is a beta blocker, you give that, it's going to block what epinephrine does. Epinephrine normally will increase the heart rate, increase contractility. You give propranolol, not allowing it to do that, automaticity of the heart takes over. Keeps the heart rate at a certain contractility, certain heart rate. The therapeutic index is just basically concentration index, and where you want the concentration to have an effect, but obviously not be at the toxic levels. You give medication at the wrong concentration, subtherapeutic dose never does its job. Okay? It's not that you give a little bit and it's just going to have a little bit of an effect. No, it has to reach a concentration level, bind enough of those receptors to have an effect. A smaller dose doesn't necessarily mean smaller effect. Oftentimes it means no effect, right? Therapeutic dose is what you want. You give too high of a dose, then you're into those toxic levels where it's binding too many receptors, has too much of an effect, right? And that's the potency and the efficacy of a drug. And that's how we're trying to figure out the concentration, how it's absorbed, what the concentration is going to be in the general circulation, so that we can make sure that it's therapeutic but not toxic. Factors that affect this is age, body mass, gender, time of administration. Why does gender matter? Male and female. Same age, same weight, male and female. Why does it matter? What's that?
Hormones.
Hormones can affect it, true. Body composition, so that is surface area, right? Just because, I mean, even if you're the same weight, a male and a female is going to have much different surface area. So that's going to affect how those medications act and react. And then, of course, time of administration, because you have to know. That's why, you know, anytime you guys pick up an overdose of whatever it is, most important aspect of that is when did you take that medication, right? Because, I mean, that's key. If we don't know when, then we're just treating, you know, kind of in the dark. We don't know where that medication's at, where the concentration is going to be at. If we have to wait for a lab or something like that, then you're already, you know, past those time periods you need to treat. So time of administration is obviously very important, especially for what you guys are doing. Other factors, you know, pathological state, how they're doing overall. Genetic factors play a part in metabolism. Some people just have better metabolism, better genes than other people. We call some of these people just bad protoplasm, where everything is wrong with them. And you know, that some of that stuff is obviously choices and how they live. Some of that stuff is just genetics. And then just the environment that they're in. So special considerations: geriatric patients, pregnant patients, pediatric patients. These patients obviously don't work in the same parameters as everybody else. Geriatric patients generally have a decreased cardiac output. Their heart doesn't work as well. Their kidneys don't excrete as well. So those concentrations, those medications are going to stay in their systems a lot longer than the average person. So what it says on the box, I'll give every 6 to 8 hours, doesn't necessarily apply to your general geriatric patient. And if you give a medication the way it's prescribed on a box, those concentrations might increase over time and get to toxic levels much quicker than just an average person. And then, of course, they got decreased brain mass overall, and that will affect certain medications that they're giving. Geriatric patients also have decreased total body fat, decreased body water. They don't have as much albumin. Albumin, you know, is key in transporting medications to the tissues that they need. And then their lungs don't work as well. Pregnant patients, increased cardiac. Pregnant patients are tough when giving medications because they have increased cardiac output, increased heart rate, increased volume because they're retaining fluids, right? That's why their feet get all swollen. That's why women are just flipping miserable during pregnancy. My wife always hated those ladies that were like, oh, I love being pregnant. I feel this bond with my baby. She's like, oh crap, every day sucked for 9 months. She's like, I hated being pregnant. I'll never do it again. Pregnant patients, although they have all of this stuff that's increased, overall they have less albumin, they have less protein binding, they have decreased liver function, and in general their blood pressure is lower. Even though their heart rate's up, blood pressure is lower because it's an effect of it needs an exact pressure regulated across that placenta for appropriate circulation in the fetus. So that is maintained pretty meticulously by the body during pregnancy. And then, of course, the effect of those medications, some medications cross the blood or cross the placental barrier, right? So if you're given a concentration that would be normal for a woman, but that's crossing the placenta, obviously that's going to be a concentration that's way too high for a fetus. Pregnancy categories for medications. Generally, you can give category A and B. C, these are medications that are iffy. We don't really have any proof that they have negative effects in pregnant ladies. They do have negative effects in animal studies, so we're not going to test them on pregnant ladies. So category C is kind of that gray area. Well, you might have these complications. You might not. We don't know. D and X, these are contraindications. You don't give those medications to pregnant ladies. Pediatric patients. I know some people, even in this building, will say that pediatric patients you can't treat like a little adult. You cannot, because even you can't just treat on kilograms, right? You can't just treat on body weight. You have to take into effect all of the physiological changes that they have that's much different than adults. That's why we use the Broslow tape. We go off of body surface area, which is not very common because it's difficult to do, and medical control. I mean, you can check and work with each other to make sure that those doses are okay. Broslow tape is fantastic. You lay that out. You've got all the medications. You know what doses to give for those pediatric patients. And that's all for that lecture. We can take a little break. The next one's shorter, so we'll be able to get out of here a little bit early.
What's the next electric operated? Hold up.
The next one is. Let's see. Let's see, we just did pharmacodynamics and pharmacokinetics. The next one is the autonomic nervous system. Let me see. It will be, you guys are giving it in the same, it should be under pharmacology. So it's from the Bledsoe book. What we did just barely was chapter 2. This next one will be chapter 6.
I got you all set. Good to go.
All right. So give me an example of active transport.
Sodium potassium pump.
Sodium potassium. That's what I like. Sodium potassium pump requires what? ATP. ATP requires what? Right. We won't go through the Krebs cycle. We won't even memorize that bad boy. But just know that, that's your most important active transport.
Is sodium potassium pump the axons too?
Yeah.
So is that just loaded with ATP?
Yeah.
Are there? I thought it was just kind of like a synovial kind of place in there. There's a bunch of cells in there that are pumping out ATP.
Yeah. Your nerve cell. Each nerve cell has a nucleus. Now it might be a really long cell, but all of them have a nucleus, and they're loaded with mitochondria. Mitochondria are doing the Krebs cycle all the time and making ATP, so that you can have an action potential going across that nerve. And I mean, if you just get into the nitty-gritty of the metabolism of the body and how quickly a nerve impulse is, right? So how quickly each of those reactions are happening, and there's like 1 million reactions are happening just to, you know, move your finger or whatever you're doing. I mean, it's incredible how quickly it happens and the mechanisms involved in what we're talking about here. Let's see, what else? Give me an example of passive transport. Diffusion, osmosis, filtration. Good. All right. You know, I was just thinking about my pregnant wife again. And we've got 3 boys, and we're done. She actually made me get snipped. And that was just last week. I got snipped last week, and it feels like you got kicked in the nuts like over and over again for like a week.
You feel a pull on your tonsils from down there?
Yeah, exactly. I feel for my son. But I was just thinking about, because you know how, you know, ladies be like, I had a baby and my hips got bigger. When I got into medical school, that is absolutely true. So the symphysis pubis that holds the retinaculum, that holds together your pelvic girdle and those pelvic bones, stretches for the baby to, you know, get through the pelvis, and that doesn't go back together. Like, that doesn't tighten back up. So the hips actually do get bigger.
You didn't say that though, right?
No, honey, you look great.
Kept that to yourself.
Yeah. Jill, see, I wasn't lying.
Give her the medical reason.
Yeah, exactly. No, my wife's funny. She's like, you know, I've been graduated from medical school for 8 years or something now, and my opinion means nothing to her. Like, I'll try to give her some kind of explanation, or, you know, she'll ask me something and I'll examine her or whatever. She's like, well, why don't you call so and so? Like, she doesn't believe that I know anything. Yeah, exactly. It's a little bit ridiculous, but and now she blames everything on the avalanche. Like, anything that I do or say that is questionable, she'd be like, brain swelling, guys, brain swelling. Yeah, it's pretty low. So, all right, let's get back to the
new car.
We'll get back to the. So this is chapter 6. This is the autonomic nervous system. Hopefully, this is a lot of review for a lot of you guys with the autonomic nervous system. So, autonomic, obviously, that means automatic, right? So you don't have to think. You don't have to. This is involuntary actions of your nervous system. Objective. So this is describing the anatomy of your nervous system. Nervous system's broken up basically into 2 groups: your sympathetic and your parasympathetic, right? And then we'll go into the function of the sympathetic nervous system. We'll also go into the function of the parasympathetic nervous system, but we'll talk about the adrenergic receptors, you know, the main ones that are affecting your organs, and especially the ones that are pertinent to what you guys are going to be doing. So, nervous system, broken up into the central nervous system and the peripheral nervous system. Central nervous system is your brain and your spinal cord, right? Anything outside of that, anything outside of your brain and spinal cord is your peripheral nervous system. So that means cranial nerves. How many cranial nerves are there? Good. And all of your peripheral nerves, everything coming out of your spine, that's peripheral. So you got autonomic nervous system. That's broken down into the sympathetic, parasympathetic, and then also part of the peripheral nervous system is your somatic nerves. What's somatic nerves? Yeah, these are voluntary. Mostly these are muscular control for the most part, right? Voluntary. I know some people that can, like, gleek. Any of you guys can gleek, like voluntarily gleek? you know what I'm talking about? So your salivary gland that's underneath your tongue, some people can, like I have a friend that can just go ahead and he can leak right out of his tongue. Like it's not spitting. He's
Usually when I'm talking to somebody
voluntarily.
really important, it happens.
Yeah. So somehow some people can get control of some involuntary movements. I don't know. Maybe it's a muscular function that he's just flexing certain muscles in his tongue. I don't know. So nervous system. This is your body uses. This function is basically to regulate your organs, right? So this is involuntary visceral responses. Visceral responses means organ responses. This is regulation of your cardiovascular system, blood pressure, cardiac output, stroke volume, all of that stuff. Respiratory system, and a lot of that is based on pH, like what you guys learned about this morning, right? If pH changes, your respiratory rate or strength, I guess, changes to try to, your respiratory system tries to compensate for the metabolic imbalance, right? Digestive system, urinary system, reproductive system is all controlled by your nervous system. We talked about the two major divisions there. This is your axial system, central nervous system, brain and spinal cord. Then your peripheral nervous system, you've got cranial nerves, you guys already said, there's 12 pairs. And then your spinal nerves, there's 31 pairs of spinal nerves. And then this is further divided into the somatic and then your autonomic. So a lot of pre-hospital medicine is geared towards the autonomic nervous system and geared toward both sympathetic and parasympathetic. And you guys have to always be thinking in any kind of tox case. Tox cases are always the most confusing because you're trying to organize all of the different symptoms and physical exam findings and trying to put that into what is going on. Is this a sympathetic overdrive or is this a parasympathetic inhibition causing a sympathetic overdrive, right? And you're going to treat those differently. So you always have to kind of keep those in mind and all of that. I think in your guys' slides there's a spelling error and I changed that to parasympathetic. I can't remember what it's. Yeah, your guys' says peripheral. But yeah, that should be parasympathetic. So your sympathetic nervous system. So this is fight or flight, right? So this is a stimulatory drive. What happens to your pupils in the sympathetic drive? They constrict, right? And that's all based on the ciliary muscles in your iris, right, causing that constriction in a fight or flight response. Also part of this, this sympathetic system, it's not always just nerves, it's also neurotransmitters. And that's mostly, when we're talking about neurotransmitters, we're talking about the adrenal medulla, that organ sitting right above the kidneys, where you're getting all of that blood flow all the time. Remember we talked about before, 20% of your circulation at any given time is in your kidneys. Your kidneys are just receiving an enormous amount of blood flow all the time, and so a lot of your regulatory system is in your kidneys. Your kidneys will affect your blood pressure. Kidneys will affect your heart rate, and the kidneys will release the neurotransmitters, epinephrine, norepinephrine, in order to change some of those things, based on what kind of blood flow it's getting at any given time. We're not going to go through the nitty-gritty of all of this stuff right here, because I think it's better explained in later slides. But this is just kind of the physical divisions of the sympathetic nervous system and going to the different ganglions, there's preganglions, and then getting to the ganglions. Basically what you need to know is that the preganglions are going to be right outside of the spine. Those ganglions that are right there, that's kind of the ganglion system. that those impulses and those neurotransmitters are kind of stored, and then that signal is sent down the nervous system. Then the ganglion are usually those nerve bundles that are right there at the target organs. Okay? And then it goes to the target organs, and then you get your response. So, further division of the autonomic nervous system, what we were talking about. So your sympathetic division goes to that preganglion. The preganglion are those segments right outside the spine. So that's T1 to L2. You've got all of those, I mean, they look like nerve bundles right outside the spine. Those are preganglion bundles. And then your ganglionic, those second order neurons, are closer to the target organs. You've got sympathetic chain ganglion, your collateral ganglion, and then the adrenal medulla is part of that ganglionic neurons. The adrenal medulla is just different in that it sends, instead of sending a nerve signal like these ones do in these postganglionic fibers, they send neurotransmitters then into the circulatory system that then affects the target organs. So direct stimulation, this is increasing the heart rate, you get sweaty, constricts the blood vessels in the skin. Then your collateral stimulation is the stuff that it's doing also to help the direct stimulation. So if we want to increase the heart rate and increase central circulation, well, then we're going to reduce blood flow in the abdominal organs. That's why they say, you shouldn't exercise until 30 minutes after eating, because you've got this tremendous amount of blood flow going to your organs, trying to absorb all those nutrients that you just ate. And if you start exercising, that kicks on your sympathetic system, takes blood flow away from that digestion where it's trying to do, and that's why you get stomach cramps. Your intestines start to go, wait, I still got all this crap, and you took away my blood flow. Now I'm going to be pissed off. So decreased digestive activity, and this is also why people that get really scared pee themselves. It turns on that fight or flight response, and it totally relaxes their bladder muscles, those smooth muscles in their bladder. And if you've got too big of a response, they can't even help it. They can't hold that in anymore, and they'll pee themselves. Also part of the direct stimulation, this is blood flow to the muscles. You need increased blood flow to those muscles because it's a fight or flight response, right? We're gearing the body up to get out of there or fight. We're increasing your lung capacity with bronchodilation, increasing breakdown of glucose in the liver so we can get more glucose into the bloodstream, more glucose, more ATP, quicker response, right? And then collateral stimulation is your releasing that glucose from the liver, breaking it down, and then you're releasing it. On a side note, and this doesn't have anything to do with you having to know any information for a test, but glucose storage in the liver is stored as glycogen, right? Glycogen is also stored in adipose tissue. So, as a side note, fat doesn't make you fat. Fat does not get broken down into glucose and get stored as fat again. So that's a misnomer in nutrition. Fat doesn't make you fat. Sugar makes you fat. And our diets these days are so inundated with sugar, right? Everything has a ton of sugar in it. Sugar makes you fat. Fat doesn't make you fat.
So what does fat?
It's broken down into different fatty acids and used, but sometimes it's used to store sugar. But if you don't have if you don't have that sugar to store, that fat is bound to bile, and you get rid of it. So the body only absorbs the fat that it needs to bind other stuff that you're putting into it, right? So if it doesn't have that other stuff that it needs to bind and store, your body just gets rid of it. So your body will take fat and use it if you're also pounding cupcakes and it needs more fat to store more sugar, because the body is designed to keep sugar. because it needs sugar, and it's going to store sugar in times that you don't give it sugar. So, again, fat doesn't make you fat, sugar makes you fat. Right?
Again.
All right. So back to the lecture. Sympathetic nervous system. So your main neurotransmitters, epinephrine and norepinephrine, and they target adrenergic receptors on different tissues. Your adrenergic receptors are what? We talked about it earlier. These are your like alpha receptors, beta receptors, right? These are what these are the receptors that are waiting for the neurotransmitters to bind to it to start a reaction and affect that target organ. Yep. Those adrenergic receptors are located on the cell membranes of those target organs, and those organs have very specific receptors. And depending on what that organ's function is or what it's supposed to do, it'll have more of one kind of receptor than the other kind of receptor. Like your heart has a ton of beta receptors, right? And it has a certain kind of beta receptor. So this is an example of that synapse, of the adrenergic receptor. So this right here is your target organ. And these are those receptors. These are proteins. They're just waiting to bind to a neuroreceptor, right? This is your nerve. You can think of this as your nerve. Your action potential is coming down your nerve. That's why it has a mitochondria, is because nerve cells have a ton of mitochondria in order to create all of that ATP to get a quick signal. That action potential is causing a signal that's telling all of that stored norepinephrine or that neurotransmitter to then be released. It gets released, it binds to the target organ, and that target organ has a function. You know, if that's the heart, norepinephrine binds to the heart, increases the automaticity of the heart, right? Increases that heart rate until it wears off. When norepinephrine gets broken down, metabolized into an inactive form, that gets reabsorbed into that nerve cell and then gets made into and stored as the norepinephrine again. We'll talk about this with acetylcholine too, because it's important with acetylcholine, especially with what you guys do and with paralytics, right? And how paralytics work. So these are your adrenergic receptors, alpha 1, alpha 2. Alpha 1, this is peripheral vasoconstriction, increased contractile force, decreased heart rate. So it has a negative chronotropic effect. Alpha 2 decreases your catecholamines. What is catecholamine? Best example of catecholamine is acetylcholine. So if alpha 2 decreases acetylcholine, decreased acetylcholine means generally a bump in the opposite, right? If you're decreasing your acetylcholine is your parasympathetic drive for the most part. You just kind of remember that pattern. Acetylcholine goes with parasympathetic, usually slows down your system. If you block the acetylcholines, then your system's going to ramp up, right? Because you don't have that controlling factor to keep it slowed down. Beta 1, increase your heart rate, increase contractility force, increases the automaticity. What's the automaticity? Yeah, how your conduction system in your heart regulates your heart rate, right? So if you got something that's increasing that automaticity, then your body at that period of time can't slow its heart rate down. Beta 2 is peripheral vasodilation. So this is what we're talking about in selection in certain medications. Propranolol blocks both beta 1 and beta 2. So it affects bronchodilation, whereas metoprolol doesn't affect beta 2, only affects beta 1, unless you have a super high concentration, like an overdose of metoprolol, then it will start to block beta 2 as well. All right? That goes along with a lot of overdoses. Medications are generally designed to block certain things, but if you give them too high a concentration, it's going to start blocking everything, right? Or if it's an agonist, affecting everything. All right. part of those adrenergic. All you have to remember as the 4 adrenergic receptors are alpha, beta, dopaminergic. Beta 3 is kind of a commonly forgotten adrenergic response just because we don't think about it very often, but that regulates your temperature. All right, so medications that are acting on the sympathetic nervous system are sympathomimetics. Those ones that inhibit are sympatholytics. And the same thing with parasympathetic. You've got parasympathomimetics, parasympatholytics. So EMS medications, a lot of them stimulate both alpha and beta receptors. And they can be broken down into selective or specific medications where they only act on one of those, like what we talked about before. So parasympathetic, this is the feed and breathe. Why do they call it breathe? We know why it's feed, because it increases blood circulation to your digestive system and increases digestive absorption. But why is it breathe? What's that? Because your parasympathetic system is what's responsible for an erection. The primary neurotransmitter in parasympathetic system, like what we talked about before, acetylcholine. You can always kind of remember that pattern. Sympathetic, norepinephrine, epinephrine, dopamine. Parasympathetic, acetylcholine. And then what those are doing. Acetylcholine acts on muscarinic and nicotinic receptors. Those are the different receptors in target organs where acetylcholine binds. For what you guys do, a lot of the effects that acetylcholine has, they're binding to the muscarinic receptors. We'll look at that. So the different acetylcholine binds to the acetylcholine receptors, it's nicotinic and muscarinic. And then nicotinic is your neuromuscular system. Your autonomic is both. CNS, your central nervous system, is also has both. This is your acetylcholine synapse. So your action potential comes down, releases acetylcholine. Acetylcholine gets released. Your target organs have very specific receptors that binds to the acetylcholine. And that has to get to a certain concentration to bind enough of those receptors for it to cause a response into the cell, right? Acetylcholine esterase is an important enzyme because that's the enzyme that then breaks down the acetylcholine so that it can get reabsorbed. And it breaks it down so it can't be bound to the target organ again. There are acetylcholine esterase inhibitors. So let's talk about your paralytics real quick. Your vecuronium and rocuronium, what kind of paralytics are they?
Muscular blocking agent.
Right, so non-depolarizing agents. So how do you think they act on the synapse? They're non-depolarizing. What's depolarizing? Depolarizing means that there is an active effect, right? So if that action potential is depolarized, it releases the acetylcholine, it binds to the target organ, right? So non-depolarizing means that this doesn't happen, right? Depolarizing agent is what? Sucks is a depolarizing agent, meaning that this happens, and succinylcholine makes it so that this stays bound. So it's blocking this enzyme that then would cause it to be unbound, right? It blocks that agent, so there's no inhibition there, nothing to break that down, it stays bound. So those muscles are not able to then repolarize, right? They don't necessarily stay in a contracted state because the patient doesn't, like seize up or anything. They still become relaxed. It's just that that muscle cannot repolarize to create that contraction again, right? So it stays in that state. All right. So parasympathetic system decreases your heart rate, decreases your contraction, pupillary constriction. Wait, parasympathetic. That is incorrect.
Isn't it still, because, like when you have opiates, you have constriction.
Right. So you have, yeah, you're right. You have, yeah, you're right. Parasympathetic should be pupillary constriction. Your sympathetic drive is dilation, right? So that's okay. That's correct. So this is the part of feed and breathe. Stimulates digestive gland secretion. Stimulates those smooth muscles to increase contraction and moving fluid through in your digestive tract. Causes bronchoconstriction. We talked about this. So the medications that stimulate, the parasympathomimetics, just big, ridiculous words that they make us memorize for the hell of it. I don't know. So they both are, the parasympathetic system also stimulates both alpha and beta receptors, and can be, like I said again, in a selective or specific action. So function. This is just a list of how it functions on different organs. So obviously decreases the overall function of the heart rate, and that happens at the nose, the conduction system, right? Arterioles causes dilation. GI tract causes it to increase salivation, increase secretion. So if you have a parasympathetic overdrive, you get that, vomiting, diarrhea kind of thing, and that can happen with different organophosphate poisoning cases, right? Your lungs, bronchoconstriction, gallbladder usually contracts it, and that's why people with stones have what's called biliary colic. They eat something fatty, eat something with high protein that's going to require bile to be excreted to bind to that stuff so it can be digested. It causes gallbladder contraction. If they have stones there, it's contracting down on those stones. They have a lot of pain if they eat a big meal. That's called biliary colic. If it gets too bad, then they have cholecystitis, where it actually becomes inflamed, and you have to take that sucker out, right? All right, we talked about a lot of this stuff with the rest of those organ functions. But the liver, this is glycogen synthesis. So this is, you just ate a big meal, your body's going to digest all that sugar that you just got from that meal, and your liver is going to start to store that in glycogen. All right. Let's see. This is just a comparison. So this is an important list because this is kind of a summary of a lot of what this lecture is about, with the differences between the sympathetic and parasympathetic and how it acts on the different organs. And if you can kind of think of all of these things conceptually, then it's always going to make sense, right? If in a parasympathetic state, what do you think your body is going to want those different organs to do in order to create that state, right? So if you can kind of think of it conceptually, you don't always need to necessarily memorize that chart because you'll know what that organ should be doing in that kind of state. All right? That's the end of the lecture. Questions? It wasn't that bad, right?
Which part's going to be on the test?
The objectives in the beginning of the chapter, you can answer those objectives. You're going to be in good shape. That chart's going to be important in the effects on the different organ systems.
Question.
Yeah.
It says that the pupil dilated with sympathetic stimulation.
Yeah.
We've also been talking about constriction of pupils, like focus. So in other place, is there you dilate to see more? Do you constrict to focus? Trying to get a concept.
Yeah, the conceptual. All right. Well, let's think about it for a second. If you're in a flight or fight response, sympathetic overdrive, what are your eyes trying to accomplish? Right, so you're not in a relaxed state, right? So in general, so let's see. So your confusion is based on this.
Yeah, I think that's backwards.
This chart, right? So sympathetic cause dilation, parasympathetic stimulation, constriction.
Yeah, if you think like heroin overdoses, it's a CNS, so they're constricted.
Right.
Whereas like meth is a stimulant, so their eyes are huge. So kind of like sympathetic dilation, letting as much light in. That's kind of how I'm.
Yeah,
That makes what you have to do. So CNS, so if your central nervous system is relaxed, you'd like heroin when you're constricted because your brain doesn't care about taking in.
Right.
I don't know.
So think about that is with your medications or your stimulants acting on these different sympathetic and parasympathetic systems. If you give epinephrine, if you give cocaine, if you give any of those things, right? Dilation. You give anything that's going to stimulate that parasympathetic system, and you cause that you get miotic, right? You get that constriction. And in a fight or flight response, it's you're trying to open up that vision, right? It's part of that response. You want to be able to see everything, and it's going to cause that dilation in an excited fight or flight response. All right. And then when you're, relaxed and eating and digesting, you're not needing to see all that well, go anywhere, do anything. You get that vasoconstriction. Maybe that's why when I'm watching the Super Bowl, I'm always like squinting and I'm trying to, what the heck is going on? I can't see the score or whatever. I know, right? A little cocaine would help my Super Bowl experience. Or glasses, cocaine or glasses. Either one would probably do the job.
Yeah. There you go.
All right.
So is the whole discussion in here about the ganglia just getting into the weeds? Is that important? Or
Getting into the what?
the weeds? Are we just?
Cocaine or weed?
I'm talking about the ganglia nerves. It really spends time on that, but is it?
Yeah. You really stressed it in the book.
The reason why it's good to know your ganglions is because that's where a lot of the neurotransmitters are stored and kept and released from there. And that's basically, the ganglion is just the anatomy of the nervous system, the peripheral nervous system, right? So all you need to remember from that is the preganglion is the location basically right when it leaves the central nervous system and goes into the peripheral nervous system. That's right where the preganglion is, which is where all your spinal cords are, right? That's T1 to L2. You've got preganglion lining all of those spinal cords. And then you have your preganglion fibers that are then going to the ganglion, and the ganglion are usually right there where the target organs are, right, where it's being affected. And then from the ganglion, you've got your nerve fibers that are going out and either directly affecting like a muscle, or you've got neurotransmitters, like the adrenal medulla is considered a ganglion. It's in that same ganglion system, and it sends out the neurotransmitters the same as a ganglion at a target organ, like at the heart, is going to send out its signal. All right. Other questions? You guys want to summarize any more? Or are you guys spent for the day?
That's about right.
I think it's so So I've been reading this book. I've been reading this book on habits and willpower, and there's been countless studies, especially in the last probably 20 years, that willpower is a lot like, I mean, it acts like a muscle in that you can use up willpower. So if we had maybe attributed that to today's lectures, where I was supposed to actually lecture yesterday, so that we maybe could have broken some of this stuff up, because your willpower was probably spent this morning. Yep. And then by the time we get to these lectures, your willpower is already gone. So in your mind, you know, that's already spent. So you're like, I'm just gonna have to study this real hard later, because right now I just can't get it.
You're in my head, man.
Yeah, right? That's been studied many times, and they talk about that in business and everything else when you're trying to get the best effective employees and learn and train individuals in different areas of business or medicine or whatever, is that you have a finite amount of willpower, and once you've spent that, it's done, and they have to recharge and regain that willpower. But you can train willpower in that you can face adversity on a regular basis and increase your willpower, increase that muscle so that you become more effective for long periods of time, and you don't have this afternoon lull of, oh crap, I'm going to learn this later. What's that? Yeah, see, we're training you guys. So by the time you become paramedics, because medicine is one of those areas where they're looking at willpower over and over and over again, because and that's what they do in residency, right? They make those residents know the information, be able to do that under circumstances where they've been awake for 48 hours already. Their brain should not be able to function, but they still have a routine and they can still do things. Probably not very safe, but they can. They've increased the willpower of those people. But like you guys as paramedics, if you have a really hard case, you just ran an arrest and you had to bring him to the hospital from 45 minutes away, your willpower is spent. The mistakes don't happen in that moment. It usually happens in the next two, ambulance cases or calls that you guys get. And they've looked at that in willpower. The mistakes don't happen in that serious case. That happen in the next mundane case. That you normally would never make that kind of mistake, right? Interesting stuff. But the point of that is that you can increase your willpower, and that's what we're doing here. We're trying to build you guys up so that when you get out into the field, you won't suck. Words of wisdom.
Calling you weak.
What's that?
You're calling him weak, right? Not me. You're talking to him.
I'm not calling any of you weak. All right, you guys are done. You can get out of here, unless you got more questions. Oh yeah, they're gonna want come in and.
It seems too good to be true.
If I send you guys all home right now, Gary's gonna be like, "What the hell, man?"
Dr. Rankin said let's go.
Do it now. Do it now. Not approval.